Are we all back together, or are we still missing a breakout room?
It's like we're still missing most of Dr. Koo's group.
Okay.
I'm sure they're having a very good conversation.
We're about to get thrown out, so
Forced back to the main room.
exactly.
Oh, hi, Tyler. Good to see you. All right, I think the gang is all back. So Dr. Koo, can you hear us?
Yes, I can hear.
Perfect. All right. So I think if we just want to go around robin and kind of talk about what our groups talked about, we do have a discussion question from our group if we have time that we'd like to talk about. So I can go first if that sounds good.
You're on.
All right, cool. Well, I think I was very spoiled in my group. We had a nice mix of pharmacy, infection prevention, as well as physicians. So we did talk about, the first question of testing for viral infections, and it does sound like all of the facilities in my group were testing for COVID and influenza. Some facilities have the ability to do, quad testing and testing for flu, RSV, COVID. We did talk about, with question number 2, that some facilities wish that they had a broader respiratory panel. So, that they were able to identify maybe more organisms or pathogens. And we did talk about the challenges related to, getting certain antibiotics and antibiotic shortages. We talked about, if doing the viral testing, and if negative, then doing some other additional testing and using x-rays for pneumonia and doing blood work and things like that. And Jenner had mentioned, if patients needed increased oxygen required. One kind of, I think, barrier that we identified in our group was related to antibiotic prescribing, was the transfer of care and handoffs. That can sometimes cause some issues with antibiotic use and prescribing practices. Steve, who is a pharmacist in our group, he's from Sydney Health, and he's just starting his AMS program, I think shared some great words of wisdom of, taking the approach of making antimicrobial stewardship as and prescribing practices as a standard that they all agree upon. So really, creating that culture and that group understanding of practices. And then Adam, who's a provider at Mountain View, helped us kind of, get that provider perspective of creating a culture of education and building team using data. And they shared the data that they were collecting, which was really nice to hear that they were collecting data, but they were also using it to make informed decisions within their healthcare facility. We really focused on, not being punitive, but creating a culture of safety and protection and doing best practice medicine. And then our discussion question that we can discuss after all groups present is, how much teeth does an AMS program have? And what do you do with these teeth? And how do you work with providers that may not be following best practices and things like that? So that was our group. Did I miss anything? Melanie or Melissa or who else is in my group? Adam, Steve, did I miss anything? Jenner?
I think you hit it. That's the meat and potatoes of it.
Perfect. All right, Vince, I can hand it over to you.
Thanks, Erica. So I had a good group that was very willing to share some information there. So with regards to the first question in terms of testing for viral infections, and I kind of expanded that a little bit to most everyone had indicated that it was a true protocol or process was not typed in, so that it was just protocolized within that system. Most of the respondents in our group suggested that it was provider dependent in terms of all the initial diagnostic testing and orders written and so on and so forth. The viral entity, most places do test for the viral components of that, influenza, COVID, RSV, and so on and so forth. And then some of the other testing labs and so forth, CBCs, chest x-ray. Most everyone started with the chest x-ray, but they had that shotgun, that battery of initial testing to kind of aid in the diagnosis of the diseases there. But again, mostly provider dependent and provider specific on that. So the second question there about worried about secondary bacterial infection and so on and so forth. Most Clark Fork Valley, Sydney, so on and so forth, Emily, Ashley, everybody was kind of on this, had a wait and see type of an approach before any de-escalation or discontinuing any antibiotics, or even to start the antibiotics to wait and see what the actual initial diagnosis was. Again, there was a caveat of some specific providers not being kind of not necessarily rogue, but kind of going by their own set of orders there. But most everyone took a wait and see approach to start the antibiotics and or to start at that point in time. So if the process was or the patient was not progressing, then at that point in time, duration actually triggered a little bit more of the antibiotic approach if there wasn't anything on board at that point in time. The other thing that we talked about, and I think most of the people kind of bought in, Dr. Williams at Clark Fork Valley was very nicely described in terms of different patients that had different risk factors, immunocompromised status, comorbidities, and so on and so forth. Would it be advantageous to be more aggressive or assertive in that patient? It's case by case basis, but I think that was probably reasonable. Ashley was or Ashton, excuse me, had mentioned a duration in terms of either starting and or stopping antibiotics was a critical piece, and the patient's history in terms of did they have a history of community acquired pneumonia or bacterial, or that transition from viral to bacterial, and that was another key factor in whether or not antibiotics were prescribed there. As far as imaging went, most everybody went with the chest x-ray and along with the other diagnostic tests up front. If there was some reason to forward that to a CT or other types of diagnostic imaging, that more went with the case-by-case basis. If it was there was an elevated D dimer, or the patient wasn't improving, or the chest x-ray was unrevealing to the point of the seriousness, didn't match up with the symptoms, and they needed some more diagnostic imaging, then that ended up being they would proceed to different types of a CT imaging. And then this issue of, I kind of pose it as if you were king or queen, you had issue, how would you incentivize change in that setting? And I think everybody's kind of running parallel courses here. It's the Ashton had provided some information, from a peer group of practitioners. If we're looking at that, what is it, data driven? Seemingly, is it evidence based? Sure. Is it we all want to do the same thing, so we don't have we're not inconsistent in the way we approach it. Absolutely. So that seems to be a pretty good theme. That said, if you have that rogue individual that says this but does this, then how do you rein that individual in? Jean's taken on the role of being the mean doctor and kind of going after somebody, so when they see her coming, they know what to do, and so she can her reputation precedes her footsteps down the hall, as it would be. That's good. I think it's going to take a combination. I brought up the issue of would patient education, those that are going, because time and resources are an issue. And so, if you had pharmacy education, IP education, we approach the public as well as the practitioners in terms of needing and where antibiotics fit in. Everybody seemed to think that was a pretty good idea. So other than that, it was a pretty good discussion. So I'll cut it off right there and let Neil talk. But if I missed anything in our group, please correct me or speak up. But again, thanks for your participation. It was great. Hearing none. Neil, you're up.
Okay, I'm gonna be real quick. So, had a nice discussion with our group as well. Seems like most of the hospitals there are testing for viral infections. But interestingly, it seems like that they tend to focus on cheaper antigen-based tests because of cost issues with all the multiplex PCRs and such. And the multiplex PCRs are mostly more reserved for sicker patients. In regards to antibiotic use and concerns about secondary bacterial infections, usually the biggest driver for those are in two populations. One is those who had been diagnosed with a viral infection, but then later continue to have symptoms or have worsening of symptoms. As well as those hospitalized patients who are just really sick. So now regarding how there's anything incentives to kind of stop antibiotics or not to start antibiotics, it's interesting that many of these hospitals actually don't have rely on, at least the ones I've talked to, rely on chest imagings and such. Although at my site, we do. So I'm seeing like Billy kind of seems like, the radiologist says there's pneumonia in chest x-ray, they'll still treat it regardless, which is good. I'm glad that that's not as big of an issue. However, I have suggested about using procalcitonin as an indicator, but that is a big, but unfortunately, many sites don't have the ability to get those results back in a very fast, in a short period of time. And therefore, it's not actually very useful for many critical access hospitals. And even at Billings Clinic, we send our procalcitonins out. So we'll get it back in a day. But even that is not a very useful, that turnaround time is not very useful for clinicians. It may be more better for for someone with the bacterial pneumonia that have been treated, seems to be better, and then later on. But it's not good for in the beginning to decide whether someone should be starting antibiotics or not. Two other things about interventions and such as that, I know there's a lot of discussion about education, and certainly doing the peer-to-peer discussion is it may be something that could be employed to try to promote better antibiotic use. But there is a little bit of discussion about how if we set up protocols that being a little bit more restrictive may be more effective than just hoping that someone than just education alone. But try to we kind of expanded that discussion to more that that instead of having some having this as a collective agreement rather than someone goes up and say, this is how you should do things, would be more effective. And so it sounds like that's more in line with you, Erica, as well as Vince, that a collective approach and such. So I do have one comment, and I think what Erica, you just had said, and there is a notion of something what now in the literature called diagnostic momentum. And that is a very big issue as well. I didn't touch on it with that group, but I wanted to point it out because this is something that many places see. And that is when a diagnosis is made, particularly in the ER by an ER doc or somewhere outpatient, that when the care of that patient's been transitioned to another service, that diagnosis gets carried over, even though that that it may that may be the wrong diagnosis. And that the implication of that is that antibiotics tend to continue if someone gets an ER doctor diagnosed someone that they felt that needed to be on antibiotics, but that turned out to be not the diagnosis, antibiotics continue to be on because there's a fear that the clinician may be missing out may not have the complete picture, and they don't want to undertreat the patient. And that's a tough thing to kind of, another very big issue to kind of address. So I just want to kind of point that out because Erica mentioned that diagnostic momentum is really hard to get, and that makes it tough to stop antibiotics, especially by the like the hospitalist who picked up the patient overnight, and he doesn't know why the antibiotics aren't. But the assumption is that, well, that ER doc must know something I don't know. I'm afraid to stop the antibiotics, and that's a hard thing something that it's a big challenge. And this is experience from everyone. But thank you for bringing that up, and we may have a discussion on how to address that in the future. But that's something definitely worth noting.
Thanks, Dr. Q. Vince, it looks like you were gonna maybe say something.
Yeah, the only thing one of the, I think Gene brought up a really good point about outpatient versus inpatient. The outpatient, that's an easier pot of problems, I guess, to immerse in, and that is because it's much easier to provide, just get a, an earful of complaints and symptoms and so on and so forth, and then prescribe based off that, as opposed to getting a battery of tests. And so if we had a way, based on our conversations there, if we had to weigh between inpatient and outpatient, the outpatient problem of antibiotic overprescribing, or possibly even underprescribing, or suboptimal prescribing, seems to be bigger than the inpatient side, from what I gleaned.
Perfect. And as I think we're getting some chats back, but I know we had some providers on today's call. And so, we really want to hear from you. If there is a topic that you would find helpful or useful, especially related to education, as I think many facilities are kind of trying to get their AMS program back off the ground, after going through 2020 and 2021 and having to kind of put it on the back burner, really trying to get their AMS programs going again. So it looks like I've got two topics: selection of limited use antibiotics, as well as outpatient prescribing versus inpatient prescribing. So our group can go back and chat about topics for future presentations. But if you have ideas for other topics, please feel free to email Jen or Vince, myself, or Dr. Q, and we can definitely add that to our agenda of things that we can put together for you. Our next MASC webinar will be on Wednesday, February 1st from 11 a.m. to noon. So any other final comments or questions from either the group members or from Vince, Jen, or Dr. Q before we end today?
Okay. Thanks for everybody's participation. It was great today.
Wonderful. Thanks, Tressa. That sounds awesome. Yeah, just let us know. We want to make sure that these are helpful and timely for you guys and a good use of your time. So as always, thank you so much for joining today's MASC call. We will talk with you all next month, and I hope you all have a wonderful January. Bye, everybody.
Bye.
Thank you.
So Jen or Sandra said she really likes the breakout sessions, so we'll keep that in mind.
She also engaged the most.
Oh, did she? I
Yeah,
love Sandra.
It's a little hard, and this is something maybe a bit a challenge for many of them, is to relate. I guess, and how do we stoke kind of like, okay, what are your concerns? Because we're kind of throwing it out.
Mhm.
I'm hoping that more like Sandra will kind of start throw out more topics, because it's not that we don't know what we're talking about. It's just what's more relevant to you.
Mhm.
And I feel like that's where I'm more concerned about. Is like maybe we're talking about that doesn't as an issue to you.
Yep.
And so hopefully we'll get more feedback from them that they're more willing to kind of provide some speak up about things that concerns more.
Yeah, agreed.
Steve is still on to Dr. Koo, and he had some really good questions too. He's a pharmacist that not long ago took over as pharmacy director.
Uh-huh.
So he had some excellent ideas from our group about things that can be helpful to him and to his staff when starting their AMS program. And Steve, if you're still listening, you're welcome to chime in.
I am. Thanks so much. I just thought I'd stay on and listen to the background and be here for that.
So we'll just throw it under the bus.
Well, like Jenner said, we're just starting our stewardship program here. And I do know that we have one peer-reviewed topic that's come up right off the top, that one of the surgeons is using a pre-op antibiotic that's probably considered a second tier or a third tier antibiotic every case. And I'm sure the reason is because he had a bad outcome at some point. And so one of my initial hurdles to overcome is when you have someone like that, or someone that loves to use, just say,